10 questions with rationales. Cardiovascular physiology. No shortcuts. Pause after each question if you need time to think. Let's go. Which vascular structure is the primary site of highest resistance in the cardiovascular system? A. Aorta. B. Capillaries. C. Veins. D. Arterioles. Pause if you need to think. The answer is D. Arterioles. Here's why. Arterioles are called resistance vessels for a reason. They are small, they have thick muscular walls relative to their diameter, and they are under tight autonomic and local control. As blood moves from the aorta through the arterial tree, the pressure drops progressively. But the largest single pressure drop in the entire cardiovascular system occurs across the arterioles. Mean arterial pressure in the aorta, approximately 93 millimeters of mercury. By the time blood reaches the capillaries, pressure has dropped to approximately 25 to 35 millimeters of mercury. That dramatic pressure drop, mostly across the arterioles, is the definition of resistance. This is also why arterioles are the primary regulators of blood pressure and flow distribution. Vasoconstrictors and vasodilators that act on arterioles have profound effects on blood pressure and organ perfusion. Know your vessels. Know where the resistance lives. Which receptor predominates on skeletal muscle arterioles? A. Alpha-1 receptors. B. Beta-2 receptors. C. Muscarinic receptors. D. Dopamine receptors. The answer is B. Beta-2 receptors. Here's why. Skeletal muscle arterioles are dominated by beta-2 adrenergic receptors, and beta-2 receptor activation causes vasodilation. Think about the physiologic logic. During exercise or stress, the sympathetic nervous system fires. Epinephrine surges from the adrenal medulla. Epinephrine has both alpha-1 and beta-2 activity. At low to moderate concentrations, beta-2 effects dominate in skeletal muscle. Arterioles dilate. Blood flow to working muscle increases dramatically. At the same time, alpha-1 receptors in the splanchnic and cutaneous circulation cause vasoconstriction, redirecting blood away from non-essential organs and toward working muscle. This is the fight or flight redistribution, blood going exactly where it is needed. According to Poiseuille's law, resistance is most sensitive to changes in A. Blood viscosity, B. Vessel length, C. Vessel radius, D. Blood density. The answer is C. Vessel radius. Here's why. Poiseuille's law states resistance equals 8 times viscosity times length divided by pi times radius to the 4th power. Read that last part again. Radius to the 4th power. This is the most important relationship in vascular physiology. Resistance changes with the 4th power of the radius. This means small changes in vessel radius produce enormous changes in resistance. Double the radius, resistance drops to 1/16. Halve the radius, resistance increases 16-fold. Viscosity affects resistance, but linearly. Double the viscosity, double the resistance. Length affects resistance, but linearly. Double the length, double the resistance. Neither has the leverage that radius has. This is why vasodilation is such a powerful tool. A 10% increase in vessel radius reduces resistance by approximately 35%. Radius, 4th power, dominant variable. Memorize this relationship. A decrease in vessel radius by 1/2 causes resistance to A. Increase 2-fold, B. Increase 4-fold, C. Increase 8-fold, D. Increase 16-fold. The answer is D. Increase 16-fold. Here's why. This is Poiseuille's law applied directly. Resistance is inversely proportional to radius to the 4th power. If radius is halved, new radius equals 1/2 of the original radius. Plug that into the equation. 1/2 to the 4th power equals 1/16. Resistance is inversely proportional to 1/16. which means resistance increases by a factor of 16. 16 times the original resistance from simply halving the radius. Let's make this clinical. A coronary artery with 50% stenosis, radius halved, resistance increases 16-fold. Flow drops dramatically, myocardial ischemia. A bronchospastic airway, radius reduced by half, airway resistance increases 16-fold. The patient cannot move air. A needle gauge change from 18 to 20, smaller radius, resistance increases dramatically. Flow rate drops, critical in massive transfusion where you need the largest bore IV access possible. The fourth power relationship is not theoretical. It is everywhere in clinical medicine. Question number 5. Blood velocity is lowest in the A. Aorta, B. Arterioles, C. Capillaries, D. Vena cava. The answer is C. Capillaries. Here's why. This answer seems counterintuitive at first. Capillaries are tiny. Individual capillaries have an incredibly small diameter. Shouldn't blood move fastest through the narrowest tubes? The key is total cross-sectional area, not individual vessel diameter. The cardiovascular system has one aorta, one massive tube, large individual diameter, but small total cross-sectional area. As blood moves downstream, vessels branch, and branch again, and branch again. By the time you reach the capillary level, there are billions of capillaries in the human body. The total cross-sectional area of all capillaries combined is vastly larger than the cross-sectional area of the aorta. Flow equals velocity times cross-sectional area. Cardiac output is constant throughout the system, the same volume moving per minute. So, as total cross-sectional area increases, velocity must decrease. In the aorta, velocity approximately 40 centimeters per second. In the capillaries, velocity less than 1 millimeter per second. This is physiologically brilliant. Slow capillary flow means red blood cells spend more time in close proximity to tissues, more time for oxygen to diffuse out, more time for CO2 to diffuse in, more time for nutrient exchange. The capillary slowdown exists precisely to maximize gas and nutrient exchange. Question 6. Which factor decreases vascular resistance according to Poiseuille's law? A. Increased blood viscosity. B. Increased vessel length. C. Increased vessel radius. D. Increased hematocrit. The answer is C. Increased vessel radius. Here's why. Return to Poiseuille's equation. Resistance equals 8 times viscosity times length divided by pi times radius to the fourth power. Resistance and radius are inversely related, and that relationship is to the fourth power. Increasing vessel radius dramatically decreases resistance. Every other option on this question increases resistance. Increased viscosity, directly proportional to resistance. More resistance. Increased vessel length, directly proportional to resistance. More resistance. Increased hematocrit. Hematocrit is the primary determinant of blood viscosity. Higher hematocrit means thicker blood. Higher viscosity. Higher resistance. This is clinically relevant in polycythemia vera. Massively elevated hematocrit. Blood becomes sludge. Resistance increases throughout. Increased risk of thrombosis, stroke, and cardiovascular events. And in sickle cell disease, abnormal red cells increase viscosity, particularly in deoxygenated states, increasing resistance in microvascular beds, producing vaso-occlusive crises. Viscosity matters, but radius matters more, by the fourth power. Question 7. An elderly patient develops widened pulse pressure. The most likely explanation is A. Increased venous compliance. B. Decreased arterial compliance. C. Reduced stroke volume. D. Increased blood viscosity. The answer is B. Decreased arterial compliance. Here's why. Pulse pressure equals systolic minus diastolic blood pressure. Normal pulse pressure, approximately 40 millimeters of mercury. Widened pulse pressure, greater than 60 millimeters of mercury. To understand why compliance matters, think about what happens during systole. The left ventricle ejects stroke volume into the aorta. If the aorta is compliant, elastic, it stretches to accommodate that incoming blood. The energy of systole is stored in the elastic walls. Systolic pressure rises modestly. During diastole, the elastic recoil of the aorta maintains diastolic pressure as it propels blood forward. This is the Windkessel effect, the aorta as a capacitor, smoothing out the pulsatile flow from the heart into relatively continuous flow through the circulation. Now age that aorta. Collagen replaces elastin. The walls stiffen. Compliance decreases. The same stroke volume now enters a stiff, non-compliant aorta. The aorta cannot stretch effectively. Systolic pressure spikes higher. And because the stiff aorta cannot store and release energy effectively, diastolic pressure falls. Systolic goes up, diastolic goes down. Pulse pressure widens. This is isolated systolic hypertension, the most common form of hypertension in the elderly. The anesthesia implications. Elderly patients with stiff arteries have exaggerated blood pressure responses to vasopressors and vasodilators. Small doses produce large effects. Titrate carefully. Their arterial pressure is less forgiving. Question 8. Which factor would most decrease blood flow if all other variables remain constant? A. Increased pressure gradient. B. Increased vessel radius. C. Increased blood viscosity. D. Decreased vessel length. The answer is C. Increased blood viscosity. Here's why. Flow equals pressure gradient divided by resistance. To decrease flow, you either decrease the pressure gradient or increase the resistance. Increased viscosity directly increases resistance according to Poisson's law. Higher resistance, lower flow at the same pressure. Among the options on this question, increased pressure gradient increases flow. Wrong direction. Increased vessel radius decreases resistance dramatically, increases flow. Wrong direction. Decreased vessel length decreases resistance, increases flow. Wrong direction. Only increased viscosity increases resistance and decreases flow. Clinically, what increases blood viscosity? Elevated hematocrit, polycythemia. Dehydration, hemoconcentration. Hypothermia, blood becomes more viscous at lower temperatures. Multiple myeloma, paraproteins in plasma. Sickle cell disease, abnormal red cell shape. And what decreases viscosity, improving flow? Anemia, lower hematocrit. Hemodilution, IV fluid administration. Hyperthermia, blood less viscous when warm. Therapeutic plasmapheresis in hyperviscosity syndromes. Question 9. The best analogy for the cardiovascular flow equation is A. Boyle's law, B. Fick's law, C. Ohm's law, D. Henry's law. The answer is C. Ohm's law. Here's why. Ohm's law in electricity states current equals voltage divided by resistance. I equals V divided by R. The cardiovascular flow equation states flow equals pressure gradient divided by resistance. Q equals delta P divided by R. The analogy is exact. Electrical current, blood flow. Voltage gradient, pressure gradient driving flow. Electrical resistance, vascular resistance. This is not a superficial analogy. The mathematics are identical. The physics are the same. Just as increasing voltage drives more current through the same resistance, increasing pressure gradient drives more blood flow through the same vasculature. Just as increasing resistance reduces current at the same voltage, Increasing vascular resistance reduces flow at the same perfusion pressure. This analogy extends to the entire cardiovascular system. Cardiac output, total circuit current. Mean arterial pressure, voltage. Systemic vascular resistance, circuit resistance. MAP equals cardiac output times systemic vascular resistance. Question 10. Which factor is most important in determining pulse pressure? A. Venous return. B. Stroke volume. C. Pulmonary vascular resistance. D. Right atrial pressure. The answer is B. Stroke volume. Here's why. Pulse pressure equals systolic minus diastolic blood pressure. The two primary determinants of pulse pressure are stroke volume and arterial compliance. More specifically, pulse pressure is directly proportional to stroke volume and inversely proportional to arterial compliance. Larger stroke volume, more blood ejected into the aorta with each beat, greater rise in systolic pressure, wider pulse pressure. Smaller stroke volume, less blood ejected, smaller rise in systolic, narrower pulse pressure. This is why pulse pressure is a clinical marker of stroke volume and cardiac output. Narrow pulse pressure, think hypovolemia, reduced stroke volume. The patient is underfilled. Wide pulse pressure, think aortic regurgitation, the regurgitant volume adds to forward stroke volume. Systolic pressure rises dramatically. Or think septic shock. Vasodilation reduces diastolic pressure, widening the pulse. Or think severe aortic stenosis. Reduced stroke volume across the stenotic valve. Narrow pulse pressure. Pulsus parvus et tardus. Small and delayed. And this is why you look at pulse pressure during an arterial line trace. Variation in pulse pressure with the respiratory cycle, pulse pressure variation, PPV, is one of the most reliable dynamic indicators of fluid responsiveness. Greater than 13% variation, the patient is likely preload dependent, will respond to fluid. You are reading stroke volume variation with every breath through the pulse pressure on the arterial line. That is 10 questions. Cardiovascular resistance and flow physiology. Your 5 things to lock in before you go. Arterioles, highest resistance vessels. Primary site of pressure drop. Poiseuille's law, resistance inversely proportional to radius to the 4th power. Radius is the dominant variable. Halve the radius, resistance increases 16-fold. Capillaries, lowest blood velocity, largest total cross-sectional area, slowest flow for maximum exchange. Pulse pressure, primarily determined by stroke volume and arterial compliance. Narrow means low stroke volume. Wide means high stroke volume or stiff arteries. And Ohm's law. Flow equals pressure gradient divided by resistance. The equation you live by in the operating room. I'm Anesthesia Buddy. Stay sharp. See you in the next one.